What's up, future respiratory therapists? In this video, we're going to break down another practice TMC exam question. It's all about congestive heart failure. You don't want to miss it. Let's dive in. All right, so let's break down this practice TMC exam question, show you what you need to look for, what you need to be aware of, and where your mind should be going as you're reading this question. Let's break it down here. You have a patient with acute congestive heart failure. Now, the lucky thing is they just told you exactly what the disease process is. You're dealing with congestive heart failure. That is going to make this a lot easier because you now don't have to figure it out. It goes on to say, as evidenced by pink and frothy secretions. Well, we probably saw that coming because once you know you're dealing with congestive heart failure, you know you're dealing with probably most likely pulmonary edema, which is evidenced by, as it states, pink and frothy secretions. It arrives in the emergency department by ambulance with a non-rebreather mask at 15 liters per minute. An arterial blood gas sample is drawn in the ED while the patient is on the non-rebreather mask. The values of that blood gas are 7.50, a carbon dioxide level of 28 millimeters of mercury, an arterial oxygenation level of 43 millimeters of mercury, giving you a saturation of 84%, a bicarb of 24 milliequivalents per liter. This is going to be important as we break down what are we going to do for this patient. Now, after evaluating the situation, you, the respiratory therapist, should suggest which of the following therapies. And you have four options here. Number one, or A, ipvb with supplemental oxygen. B, postural drainage to clear the secretions. C, mask CPAP with supplemental oxygen. Or D, non-invasive ventilation via nasal mask with postural drainage. Now this is perhaps an easy question for some of you. Perhaps it's a little bit more challenging. But here's where you want to break this down at. Let's go back and break down the question, okay? First of all, we know that the patient presents with CHF. So right there, we can put our mind in the right frame of mind. They also tell us that they present with pink frothy secretions, which tells us there is pulmonary edema present. That's important. Appropriately, the ambulance brings them in on a non-rebreather mask at 15 liters per minute. Okay, that's cool. That's appropriate. We're happy with that. We take a blood gas on the non-rebreather, and these are the values we get. Now, the important part about the value of these blood gases is, and we're going to break this blood gas down further here in just a little bit, but what we see here is an alkalotic pH with a reduced CO2. This is important because we know when we're dealing with any acute situation, if we have a high CO2 leading to a decreased pH, then we need to be thinking about how do we support this person's ventilatory status. In other words, how do we help them get rid of that CO2? But in this case, that's not what's happening. The person is getting rid of CO2 just fine, causing an alkalotic pH. So we're not really concerned about this yet. Now we're going to ask ourselves, why is the person getting rid of so much CO2? We'll talk about that here in a little bit. This gives us a PaO2 of 43. That's a problem. This is borderline severe hypoxemia. As it stands right now, we're going to put it in the moderate hypoxemia range. But considering we're on a non-rebreather, we clearly have an oxygenation problem. We have a saturation that supports the PaO2, and we have a normal bicarb. Now, the normal bicarb just tells you that this is happening from a place of normal and not from a place superimposed on chronic ventilatory failure. What are we going to do for this patient? Well, we have all the clues we need. All you need to do is ask yourself, how do I treat congestive heart failure? Well, let's look at the answers here. ipvb with supplemental O2. Now, I'm not going to mark this one off the list just yet because there was a time in history when ipvb was the answer to this question. It's not currently, and I'll tell you why here in just a second, okay? But there was a time. Postural drainage to clear secretions. Okay, well, let's think about this. And they're setting you up to choose this answer, by the way, because they told you evidenced by pink frothy secretions. So you're thinking to yourself, oh, we have all these secretions. We must help this patient get rid of them. So when you see postural drainage to clear secretions, that sounds like a viable answer. But that's not the answer when we're talking about pulmonary edema. When you're talking about pulmonary edema, you have to fix the problem. You're not looking to clear out secretions like what you would with bronchiectasis or cystic fibrosis. You're looking to treat the problem. So it's clearly not postural drainage to clear secretions. Now, answer C is mask CPAP with supplemental oxygen. This is a very good option. We're going to put a little check mark by it here right now because that seems like perhaps the best answer. But then we get to D, and we have this, well, that sounds like a good answer too. Why don't we go non-invasive ventilation via nasal mask with postural drainage? Well, we've already talked about the fact that postural drainage is not indicated in this situation, okay? So this right here partly makes D a wrong answer. The other reason this is not a correct answer is we've already discussed the fact that when we talk about non-invasive ventilation, you're typically referring to bilevel non-invasive ventilation, aka BiPAP. Now BiPAP is going to help a patient get rid of CO2. It's going to help them with their ventilation status. But we've already declared that there's no need to help this person with the removal of carbon dioxide. The other reason D is not a good answer is because this nasal mask right here. Now they put this in here and it makes it look like, oh, they're being more specific, so maybe that's the best answer. But in reality, the more specific this becomes, the less likely this is. You got to recognize that anytime you're going to use non-invasive ventilation, either BiPAP or CPAP, with a nasal mask, you're usually talking about in an obstructive sleep apnea type situation. You are rarely, especially on your TMC exam, going to choose a nasal mask to help with an acute situation. That's not the way that works. In an acute situation, we're going to be utilizing a full face mask to aid our patients. So D is not the correct answer. Now, the correct answer to this question is mask CPAP. And they weren't specific, but what they're saying is full face mask CPAP with supplemental O2. They didn't specify nasal mask. They said mask CPAP, and that's the right answer. Here's what you have to remember. When you get a patient or a scenario that is talking about congestive heart failure, the answers for the treatment, the therapeutics of that disease process are administer Lasix to get rid of the excessive fluid, and in the meantime, support this patient with respiratory therapy adjuncts such as continuous positive airway pressure, CPAP, at a range of 8 to 12 centimeters of water pressure with 100% oxygen. Now, this doesn't get detailed, but that's what it's saying. Give this person CPAP and supplemental oxygen. And what that is going to do is you are going to stent open the alveoli with the CPAP. That's going to aid in oxygenation. We need to help this person oxygenate better. So we're going to aid them by providing them with CPAP, aka PEEP. That's what the CPAP does. So we're going to, aid oxygenation while we get the fluid off. And then the other thing CPAP does, specifically for congestive heart failure, is that when we stent open those alveoli, what we get is this micro compression of the pulmonary capillaries. Now, this micro compression decreases the amount of blood flow that gets from the right side of the heart through the pulmonary capillaries and ultimately back to the left side of the heart. So if we can decrease the amount of blood that's getting back to the left side of the heart, then what we are actually doing is reducing preload. for a patient who is already struggling to keep up with the workload from the left ventricle. So if we can reduce left ventricular preload, then we can aid the left ventricle in catching up to and getting back to where it's not being exhausted by all of this fluid that is continually, in this blood that is continually trying to perfuse. Okay? So that's why CPAP is the right answer. Now, I remember I didn't mark off ipvb because I said once upon a time it was a good answer. That was prior to the implementation of CPAP. You got to recognize that ipvb, one of the hazards of it was decreased venous return. So during this case with CHF, where the left side of the heart is struggling to keep up with all of this blood flow, if we could reduce the amount that was coming back, then again, we would reduce left ventricular preload. And that at one time was a good answer. But compared to CPAP, it's no longer the best answer for this situation. So it's not A, it's not B, it's not D, it's 100% C. Now, since we're talking about congestive heart failure, I'd like to take this just a little further, if you will. Now, I have 3 questions up here. What other physical findings would you suspect to observe when you were looking, feeling, palpating, percussing, and auscultating your patient? What else do you think you would find in this situation, depending or predicating on the information we have? How do you interpret and explain the ABG results? And what radiological findings would you suspect to observe for this patient? Now, this is very important because it's one thing to be able to find the right answer. It's another thing to be able to take one question and turn it into a learning moment about the entirety of the disease process. So pause this video right now, answer these 3 questions based off of the prior information that we gave. If you have to go back, go back. But then come back to this point right here, and I'm going to go through each of these with you and explain to you what other thoughts you should have and what other concepts you can apply to this question even though they weren't asked. All right, so when we get in and talk about these other questions, because what we're doing is just challenge you to just think further beyond what the single question is. Let's talk about CHF. What other physical findings would you suspect to observe? Now, when you say physical findings, you're talking about inspection, percussion, palpation, and auscultation. These are the 4 areas of your physical assessment. Now, when we talk about inspection, we're talking about things we can see and things we can feel with our hands when we touch the patient's extremities and things like that. Couple of key findings. Because remember, the PaO2 was 43 millimeters of mercury. Saturations were, I believe, 77%. So it's not unlikely that this person is going to present with central cyanosis. Now, central cyanosis is when you look at the lips and the oral cavity, and instead of being pink, you see this slight discoloration to a light blue or a grayish color. That's a direct reflection of the severity of hypoxemia. So be on the lookout for central cyanosis. Now, you're also probably going to see jugular vein distension. This is when you look on the side of the neck and you see the jugular vein protruding outward from it. Now, this is because the left side of the heart is failing. Fluid is backing up into the pulmonary capillaries, leaking into the alveoli, causing the pink frothy pulmonary edema. But then it also backs up into the right side of the heart and into systemic circulation, where you see this JVD present. Now, the next thing we're going to see when we look at our extremities, you're going to notice several things here with congestive heart failure. You may see that your patient has cool and clammy skin. This is when you feel their hands, their wrists, their arms. You'll see the skin temperature is very, very cool. It's not warm and dry. Why? Because of the reduction in peripheral perfusion. Okay? So be on the lookout for that. You may also see where you have an increase in your capillary refill time. So capillary refill is when we take the nail bed, we pinch it, it blanches white, we let up, and then it turns back pink relatively quickly. Normal is 3 seconds. This might take 5, 6, 7, 8 seconds to pink back up, if it pinks back up at all, okay? So you're gonna see an increase in that capillary refill time. Again, another demonstration and a supportive finding of poor peripheral perfusion. Why? Because of the failing left ventricle not being able to adequately keep up with all the excessive fluid and perfuse the extremities. Now, another extremity finding you might find will be peripheral cyanosis. Now, we talked about central cyanosis over here being an indicator of severe hypoxemia. Peripheral cyanosis can also indicate hypoxemia, but also can be an indication of peripheral perfusion, which goes along with the other things we've been talking about when we talk about that failing left ventricle, right? And then the last finding you might find when you look at the extremities is pedal edema. Pedal edema is when your extremities swell because of the fluid leaking out into the soft tissue areas. This is what we call third spacing, and you see your hands and your wrist and your ankles begin to swell. You can press on these. Sometimes it'll make an indention, and that indention will remain present after you let up on the pressure. That's called pitting edema. All of this supports poor peripheral perfusion and supports the failing left ventricle, which supports congestive heart failure. Now, the P here stands for percussion. This is when you take your hand and you palpate over the patient's chest wall in a systematic form. Anything that's related to fluid is going to alter the sound of this note. Now, this note sound we refer to is either going to be hyper or hyporesonant. If it's an air disease such as COPD, emphysema, asthma, those type of diseases, or a pneumothorax, you're going to hear a hyperresonant sound. But with fluid, being the problem with congestive heart failure, leaking into the alveoli, you are going to get a hyporesonant sound. So it's going to be described as hyporesonance. Okay, and this will be bilateral as the fluid leaks bilaterally into both lungs. Now, when we talk about palpation, this is when we're assessing for tactile fremitus. We put our hands on the patient, we have them take a breath in, and we assess expansion. Now, the expansion is going to be decreased because of the fluid. They cannot get in a normal tidal volume. So you will see reduced expansion and an increase in tactile fremitus. Tactile fremitus is when you have the patient speak, you have them say something like 99, and you are feeling for the vibrations as they migrate down the tracheobronchial tree and then out to the chest wall. You can put your hands on your chest right now and say something out loud, and you will feel vibrations. If the lungs become more dense or filled with fluid, those vibrations will be enhanced, and you will see an increase in tactile fremitus. When it comes to auscultation, we are going to use our stethoscope to listen to these patients, and what we are going to find is that we'll find something similar to these findings. Bibasilar fine crackles. That's because there's a bunch of fluid in the bases of the lungs. So the fluid leaks over, and where does fluid go? It goes down. So you're going to see where, especially over your bases, you're going to hear the sound of fine crackles, where you have this air moving in and out and through this pulmonary edema. So you'll hear fine crackles. Now, there's also what we refer to as a cardiac wheeze, where these patients can be heard wheezing without a stethoscope. A lot of times you'll get called to administer an albuterol treatment for these patients for that wheezing. But there's no need for it because that wheezing is not a product of bronchospasm. That wheezing is a product of the fluid reducing the airway diameter. which leads to an audible wheeze, okay? So don't fall for that. Don't fall for giving that patient albuterol because they don't need it. We got to get the fluid off of and out of the body, out of the systemic circulation. That's what we need to focus on, which is why we're giving Lasix to get rid of that fluid to help this person with congestive heart failure. Now, the next question is how do you interpret and explain the ABG results? Now, if you look at this arterial blood gas, you see an alkalotic pH, you see a decreased CO2, you see a normal bicarb. Now, you can stop right there because oxygen, all of this down here, is independent from your blood gas interpretation when it comes to ventilation, acid-base balance. This is all you need for acid-base. And what we see here is that our pH is alkalotic because our CO2 has decreased. This is going to be an uncompensated respiratory alkalosis. Now, the other name for that is acute alveolar hyperventilation. This person is hyperventilating. They are blowing their CO2 down from normal, and that's causing the pH to become alkalotic. Now, the question is, why are they hyperventilating? And the answer to that question is because they are moderately, borderline, severely hypoxemic. So we're going to say with moderate hypoxemia. Now remember, they were on a non-rebreather. And so when you bring the PF ratio into this, you could probably make an argument that this person is severely hypoxemic. But nonetheless, they are hypoxemic, and that is why they are in a state of respiratory alkalosis, aka that's why they are hyperventilating. To fix this patient, to fix this blood gas, we need to fix the problem. The problem is the excess of fluid, the congestive heart failure causing hypoxemia. So if we can get this PaO2 up, then we can correct this because they will no longer need to hyperventilate. Okay? Now the last question here that I challenged you with was what radiological findings would you suspect to observe? And this here is an x-ray that supports congestive heart failure. It supports pulmonary edema. Your key findings associated with CHF and pulmonary edema are bilateral fluffy infiltrates. We'll break these down here in just a second. This is number one. Number two, you can see a butterfly or a bat wing shaped appearance. And then number three, you may see mention of curly B lines. There's also curly A and curly C lines, but curly B lines will be the ones that as a respiratory therapist you want to be most looking for when you take your TMC exam, okay? So these are your findings that you want to be prepared for if you're described a chest x-ray. Bilateral fluffy infiltrates, a butterfly or bat wing shaped appearance, and curly B lines. Now when we look at the actual chest x-ray, we have to remember what's happening here. The left ventricle can no longer keep up with the fluid that is coming to it to be perfused. There's an excessive fluid that we have to get off of the patient. So the left ventricle starts to fail. And when it does, it backs up, okay? Let me do it like this real quick. We have lungs here. We have left side of the heart here, right side of the heart here. The right ventricle pushes blood through the pulmonary artery to the pulmonary capillaries. And it goes throughout all of the pulmonary circulation. And then we return back to the left atrium to the left ventricle. Now what we know is when this fails, all of this fluid backs up. And it backs up throughout all of this region right here. The pulmonary capillaries back up and it becomes congested in this region here. And then that keeps going all the way back until we get back to systemic circulation as well. But the key here is look at this. Look at this area right here. There's a bat wing shaped appearance or a butterfly shaped appearance. Well, let's look back at our chest x-ray here. This is exactly what we see. Somewhere in here, you've got your pulmonary artery coming up and going to both sides. And then look, you've got all of this congestion here that is happening throughout. And if you can imagine, you can see your butterfly-shaped appearance. Not the best butterfly in the world, but it'll do. In other words, you see what we're talking about when we say bilateral fluffy infiltrates. You see throughout all of this region here, it kind of just looks like little cotton balls all throughout. And it also spreads and gets lighter as it moves outward. This is what we call vascular congestion. Vascular congestion is a key finding with congestive heart failure. So be on the lookout for that as you're looking at your radiological findings associated with congestive heart failure. And that's it. That wraps it up. We took one question and we answered it correctly. The treatment is going to be administer Lasix, place the patient on CPAP, 8 to 12 centimeters of water pressure, and supplemental oxygen, 100%. You can wean down after you get them stabilized, but initially, let's give them 100% and get that O2 reestablished, okay? Now, from there, we know that we talked about the other things. You're looking for all of your pedal edema, JVD, pink frothy secretions. All of those things support congestive heart failure, increased capillary refill, peripheral cyanosis, central cyanosis. Your blood gas did not show a need for help with mechanical ventilation. So why were they hyperventilating? Because they were hypoxemic. And your chest x-ray supports vascular congestion and reveals this increased infiltrates in the vasculature in the hilar region, which has a butterfly-shaped appearance, aka bilateral fluffy infiltrates. Now, if you enjoyed this, I hope you'll consider visiting the link in the video description below where I have created a course. This course is called the Respiratory Coach TMC Bootcamp. It's 100% self-paced learning. You will get over 50 modules just like this video. 11 hours of content, and you can get access today. Visit that link down below if you are interested. We'd love to have you join that community. You can find me on all the social medias. Instagram at Respiratory Coach, TikTok at Respiratory Coach, Twitter at CoachRRT, and Gmail, respiratorycoach@gmail.com. Join my texting platform right here where I send out occasional informational, educational, inspirational, motivational text. Interact with you via text message. It's a great platform, growing every single day. Would love for you to join that. And at the end of the day, remember this, future respiratory therapist. Average is easy. Don't be it.